5 by 6, we want to start. So good morning, everyone, and thank you for joining us today to our international rounds. And it's my great pleasure to introduce today's speaker, Dr. Laura Dos. Laura and I are friends for a long time. And Laura is the director of the CCHD unit in Vall in Barcelona. And Laura is going to talk today about a topic that I think is very exciting and not well known, but very interesting in congenital heart disease patients, which is the Pheochromocytomas and Paragangliomas in cyanotic congenital heart diseases. So Laura, thank you for joining us today. The floor is yours, and we are looking forward to hearing your presentation.
Thank you very much, Rafa. Thank you for your kind words. Thank you for your invitation to participate in these very prestigious rounds. And actually, the topic that I will discuss today is a bit far from what we cardiologists used to talk about in our sessions. And I apologize, first of all, if there is any endocrinologists in the audience, because maybe I will be, too simplistic to address such a complex topic, such as Pheochromocytomas and Paragangliomas. And this is the index of my presentation. I will make a quick reminder of what paragangliomas and pheochromocytomas are. What is this association? Where this association comes from? A review of the literature. Then the role of the hypoxia inducible factor in the development of these tumors. So I will share with you some results of an international collaborative study that we are working on. And then we'll discuss some future directions and some take-home messages. So I would like to start, first of all, with a couple of clinical cases. Those are real-life cases. This is a lady, a 36-year-old lady. She was diagnosed with pulmonary atresia with VSD, with non-confluent pulmonary arteries, MAPCAS, and she was deemed to be not suitable for a complete repair, so she was left uncorrected. And she had, therefore, lifelong cyanosis. Her oxygen saturations were about 75 to 80%, more or less. And with that, she was very well adapted. So she was in functional class 2 with no other complaints. But someday she had the incidental finding of a mass in the neck. So she had a whole workup, and a carotid body tumor was found, as you can see here in this. This is in the junction or in the bifurcation of the carotid artery, this nice mass here. So she had blood and urine tests which came up normal, no elevation of metanephrines in this analysis. And then she had elective surgery. The surgeon identified a highly vascularized mass that was carefully resected, and although there was a careful hemostasia, she lost half a liter of blood loss. So it's not an easy surgery. It's a tricky surgery. It's not a minor surgery for our patients. And this is the second case. This is a male. It's a 25 years old gentleman. He's also pulmonary atresia with VSD and severely hypoplastic pulmonary arteries. He underwent a number of palliative procedures, but he finally was felt to be unrepairable. So he was also left with lifelong cyanosis. His oxygen saturations were around 80%. Those are his hematocrit and hemoglobin. And he was also maybe in functional class 2, but he had multiple complaints. He was always been, felt to be somebody anxious, and he had palpitations, agoraphobia, dizziness. But finally, he also had abdominal pain. And for that abdominal pain, he had an abdominal CT scan, which showed two masses, one next to the celiac trunk and the other besides the aorta. And the blood and urine tests came up with elevated normetanephrine. So he had also this nuclear imaging, which showed both masses here. Those were paragangliomas. And this patient was felt to be too high-risk patient for surgical exeresis or resection of these tumors. So we looked for alternative treatments. And he, first of all, had a somatostatin analog for, that was the first approach. He improved, his metanephrine levels decreased and his symptoms improved, but unfortunately he developed an allergic reaction at the 5th dose. So we had to switch the strategy, and then we went to radioiodine therapy. He had received 2 doses right now, and the levels of metanephrines have been up and down. They have responded to the treatments, and right now he's quite well, both from the symptomatic point of view and also from the blood work and the urine tests. So those are introductory cases, and before talking about what is a paraganglioma and pheochromocytoma, I'd like to point out what are the paraganglia. And the paraganglia are groups of cells that are next to the autonomic system ganglia. That's why they are called paraganglia. And these groups of cells are responsible for secreting catecholamines, which have a very important regulatory role in certain endocrinological mechanisms. So those are the cells from which paragangliomas develop. So the paragangliomas are tumors derived from the paraganglia. That seems a kind of obvious thing, but I think it's important to point out. And then the second important thing here, I think that it's to stress that there are 2 different lineages of paragangliomas. We have the parasympathetic paragangliomas, which are located in the skull base, mostly following the distribution of the 9th and the 10th cranial nerves. Those are non-secreting tumors, and the most important of them is the carotid body tumor. The carotid body. As I say, that those are non-secreting tumors, but the carotid body is the most sensitive structure in our body to hypoxia. So they're responsible for the body adaptation to situations with hypoxia. It's responsible for hyperventilation, for the heart rate response, etc., etc. And then we have the sympathetic paragangliomas, which are secreting tumors. They follow the sympathetic chain along the aortic course. They are located in the thorax and in the abdomen, and they secrete norepinephrine. And we also have the pheochromocytoma, which is also called the intra-adrenal paraganglioma, that secretes primarily epinephrine. So this association between paragangliomas and pheochromocytomas and cyanotic congenital heart disease starts in this paper. This is a paper from 1964 from the Johns Hopkins Hospital, and they realized that almost a quarter of their patients with PPGL, which is paraganglioma and pheochromocytoma to make it shorter, a quarter of their patients in this institution had a cyanotic congenital heart disease. So that claimed their attention, and after that, a lot of case reports came in the literature addressing the same thing, a single or a short case series reflecting that there is an association, or maybe an association, between this cyanotic congenital heart disease and the development of these tumors. But is this a coincidence, or is this really an association? And the answer for that, it comes from this paper. This is a multi-center collaborative study that, with the collaboration of 9 ACHD units, an international collaborative study, they came up with 18 cases of PPGL in cyanotic congenital heart disease. So the aim of this paper was, first of all, to describe the baseline or the generic characteristics of these patients, and then using a large nationwide administrative database for hospitalization to see if there was really an association between both entities, or it was just a coincidence. So as you can see here, the median age at the time of the PPGL diagnosis was around 31 years. The mean cumulative duration of the cyanosis was around 20 years. and the mean oxygen saturation at the time of the diagnosis was around 87%. And using this administrative database, they identified PPGL using the ICD codes for that. They also identified congenital heart diseases using the appropriate ICD-9 codes. And they identified the cyanotic congenital heart diseases, linking those congenital heart diseases with other ICD-9 diagnosis codes as cyanosis, hypoxemia, or secondary erythrocytosis. Doing that, they could find that the risk for hospitalization with PPGL in patients with cyanotic congenital heart disease was 6-fold increased compared with the general population. But this increase in risk in hospitalization for that reason did not occur in patients with congenital heart disease that did not have cyanosis. So that was the first time that this association was kind of clarified. But what is the prevalence of these tumors in our population? So we don't have real estimates, or we don't have real figures, but we have some estimates. And here I show you a paper from the group of La Paz in Madrid. They identified from their cyanotic congenital heart disease patients. They are all adult patients that had ongoing cyanosis at the time of their analysis. They were around 200 patients, mostly cyanotic congenital heart disease, but also Eisenmenger syndrome, simple chance that developed Eisenmenger syndrome. And during a median follow-up of 25 years, they could find 7 patients with 8 tumors. So that gives us a prevalence of around 3 to 4%, depending on if we include the Eisenmengers or we leave them out of the analysis. So that's for sure quite higher than what we see in the general population based on autopsy series, or even in the population of adults with hypertension. So it seems clear that the association between exposure, chronic exposure to cyanosis, and the development of these tumors is quite clear. But does it only happen in patients with cyanotic congenital heart disease? And the answer is no. And here you can see this is a very old paper from 1973. And this explores the prevalence of chemodectomas, which are carotid body tumors, in the population of Peru. And they compare the prevalence of these tumors between people born and living at the sea level and people born and living at high altitude. And they found that people living on the high altitude had a 10-fold increased risk of having chemodectomas than people living at the sea level. So the exposure to chronic hypoxia, not only due to congenital heart disease, but also for other reasons, expose people to the development of these tumors. But the most maybe intriguing thing here, or one of the intriguing things here, is that in the last years, there have been a lot of papers, or many papers, showing that Fontan patients are also an increased risk of developing this sort of tumors. And we know that Fontan circulation is aimed at ending up with the cyanosis. We separate both circulations. So actually those patients should be out of cyanosis. But we also know that these patients may develop over time veno-veno collaterals and also have a relapse on the cyanosis over time. So in this Korean paper, there are many single cases reports, but in this case series, this is the experience of a single tertiary referral center from Korea. And they had a population of nearly 300 Fontan patients over 10 years. They found 7 cases of PPGL, so the prevalence in their population was 2.5% among those grown-up Fontan patients, with an age at the diagnosis which was quite younger than the one that we saw previously, and a time from the Fontan surgery of 21 years. Then if we consider a cutoff for diagnosing cyanosis in 90% saturation, which is something that we can see in many papers, as you can see here in that table, some of these patients had baseline saturations which were lower than 90, but some of them had this saturation which were above 90. And as I told you previously, probably these patients already had these veno collaterals that provoked this small desaturation baseline, but could provoke a more pronounced desaturation during exercise. So what is the mechanism, or who is the responsible for these findings, or for this, for all of this? Probably the responsible for that is what we call the hypoxia inducible factor. This, for those, maybe you already know that the Nobel Prize in 2019 was for those three scientists, Keeling, Radcliffe, and Semenza. The three of them developed the discovery of the different mechanisms of adaptation to hypoxia, not only at the cellular level, but also at the tissue level and at the systemic level. This is a very important finding, all this, the discovery of these mechanisms, which is a very complex mechanism. This is very important now for us, now that we are talking about this, but it's mostly important for oncology, because as you know, one of the crucial moments in the tumorigenesis is when the tumor is growing. In the core of this tumor, there is hypoxia because the tumor is growing so fast. There is hypoxia inside. So HIF is responsible for the adaptive mechanisms of tumors that make these tumors grow and survive. So I'll try to make it simple, and maybe it's too simple, but how HIF works. HIF actually is a whole family of transcription factors. And the way it works is like that. In situations with normoxia, with oxygen, we have here oxygen, and HIF alpha gets hydrolyzed, and by that it's recognized by the enzymes that are responsible for the degradation of HIF alpha. So in the presence of oxygen, HIF alpha is degraded, and then we don't have a HIF alpha activity. But when we have hypoxia, there are no hydroxylations, so HIF alpha is not recognized by the enzymes responsible for the degradation, and it enters the nucleus, binds to the HIF beta, and then binds to the DNA to the target genes that are transcribed and that are responsible for the mechanisms of adaptation to hypoxia that develop in the cell and also at the tissue level. So these mechanisms for adaptation are erythropoiesis, are related to angiogenesis, and also related to cell metabolism. So that's how cells adapt to hypoxia. But then that's how cells adapt to hypoxia, but how our patients develop the tumors. That's the whole thing. So we know that from different, there are different.
O envíale un mensajito diciendo, voy a hacer unas pequeñas rectificaciones.
There are some situations, there are genetic syndromes like the von Hippel-Lindau syndrome, in which we have what we call a pseudohypoxia situation. In these genetic syndromes, there is a mutation in any of the enzymes responsible for the degradation of HIF-2 alpha. So even with oxygen, with a normal oxygen environment, HIF alpha is not degraded and then activates the target genes. And also because it is an oncogene, HIF-2 alpha is an oncogene, those patients with these underlying genetic syndromes are known to have a higher incidence of Pheochromocytomas and Paragangliomas. Therefore, our patients that have chronic hypoxia, this is a model of pseudohypoxia. We have a model of hypoxia, real hypoxia, both the congenital heart disease patients, cyanotic congenital heart disease patients, and people living at high altitude. So HIF2 alpha that is not hydrolyzed, is not degraded, then activates the target genes, and then we have an increased risk of having Pheochromocytomas and Paragangliomas. But that's not all. To make it more interesting, we have this paper from a few years ago, from which a very rare mutation in patients with cyanotic congenital heart disease developing this kind of tumor was identified. And the mutation was in the IPAS1 gene, which is the gene that encodes for HIF2 alpha. And these mutations were located at the domain of degradation of HIF2 alpha, making this degradation more difficult and then making HIF2 alpha more active. So we have two ways of enhancing the activity of HIF2 alpha, both the hypoxia that we have and also the mutations that the mutations in APAS1 that have been discovered. Well, to look at this very rare situation, you know that Paragangliomas and Pheochromocytomas are very rare tumors, and congenital heart diseases are also rare. To make a more comprehensive approach of what is the characteristics of these patients, and also to look more in detail on the genetics of this situation, only a collaborative multi-center international study could give us some information. So that's what has been done. And this has been led by Rodrigo Toledo, which is one of the authors of the paper that I just told you about, the IPAS1 mutation. And he's in Vall Institute of Oncology here in Barcelona. So he has led this project. And what we have done is, first of all, we have identified in the literature, we have done a systematic review of all the single and case series published in the literature, from which we could obtain a structured information that then we could analyze and we could compare, and to, as I say, to look more in detail in the characteristics of this population. And also we have collected tissue samples to analyze more in detail the genetics of this disease. By doing that, we have compiled 106 published cases from 1964 from this Johns Hopkins paper, and then also 24 unpublished cases from different countries all over the world, and that is 130 patients with cyanotic congenital heart disease and PPGL. We have been able to compare some characteristics of these patients with nearly 200 patients with PPGL, but without cyanotic congenital heart disease, and this comes from large databases publicly available and also from published series. And also we have compared some characteristics of these patients with the population of cyanotic congenital heart disease from our unit with non-diagnosed PPGL. So the general information or the general characteristics of this population is that they are predominantly women. The age at diagnosis is around 27 years. The time with cyanosis is around 25 years, but there is a difference between men and women. Women are diagnosed at an older age than men. The saturation at the time of diagnosis was a mean of 83% and the hematocrit 55%. And here there's the first difference, which is that our patients with cyanotic congenital heart disease have these tumors diagnosed earlier than other people without this congenital heart disease diagnosed with PPGL. So our patients get these tumors earlier in their life. When we look at the type of repair, as expected, only a few of them had a complete repair. The majority had been unrepaired or palliated, so they have long life cyanosis or had the Fontan circulation. And as for the type of congenital heart disease, the most frequent underlying condition is univentricular heart. That accounts for the patients that had the Fontan palliation, but they are also accounts for the anatomy that is less likely to have a complete repair, as it happens with patients with pulmonary atresia VSD, which this is this group. It's Fallot and pulmonary atresia with VSD. If we compare this whole population with the population of cyanotic congenital heart disease without PPGL, the population from our unit, there is, as you can see here, a female preponderance. There's and that's not unexpected, because this kind of tumor in other populations are more frequent in female. As expected as well, when compared to, if we compare the type of repair, the majority of our patients with cyanotic congenital heart disease have been repaired. Only 15% of them will be left unrepaired or only palliated, and 9% will have the Fontan circulation. The same thing, if we look now at the type of congenital heart disease, in the general population of cyanotic congenital heart diseases, the main diagnosis is tetalogy of Fallot pulmonary atresia VSD and transposition complex in terms of simple transposition and CCTGA. And that's the difference between the two cohorts. But if we focus only in those patients that had not been repaired from our population in our series, so those are patients that had been left with cyanosis from birth, long-lasting cyanosis, we can see that the underlying diagnosis is more or less the same. Maybe in those patients with PPGL, Asian-Menger syndrome is not that common, but it's more or less the same. The difference is mainly in the time with cyanosis. Patients that develop PPGL had been for a longer time with cyanosis when compared to patients that do not develop PPGL. Maybe if we wait a little longer, maybe we'll have PPGL in those patients too. If we go to the type of tumor, you can see here that the majority of patients had sympathetic tumors. Only 15% will have the carotid body tumor, which is a parasympathetic paraganglioma. And I can tell you that no other parasympathetic tumor had been identified in this review. So all the parasympathetic tumors that we have are carotid body tumors. And this is interesting because if we look in the literature, parasympathetic paragangliomas are 70% of the extra-adrenal paragangliomas in the general population, but in our population, it's only 20%. So in patients with cyanotic congenital heart disease, we will almost always, or we will have predominantly sympathetic paragangliomas. And now, let's compare those sympathetic paragangliomas with the carotid body. They may be different. They come from different lineage. So let's see if they are different, and they are. We can see that carotid body tumors are more, this female preponderance is even more pronounced here. So they are mainly women, whereas patients with the sympathetic paragangliomas have been mostly repaired with a Fontan circulation. And in terms of time with cyanosis and age, we can see that patients with carotid body tumor will be older at the time of cyanosis, and therefore will have a longer time with cyanosis as well. If we look at the symptoms, those are the parasympathetic tumors are non-secreting tumors. So what is expected is that the sympathetic tumors will be the ones with symptoms. The parasympathetic will have only anecdotal symptoms that may be even attributable to their own baseline condition. But the sympathetic tumors, as you can see here, may have a lot of symptoms, mainly palpitations, hypertension, sweating, fatigue, chest pain, and anxiety, flushing, like our patient there. So those are the manifestations that we will see from one type of tumor and the other. And now let's focus on the Fontan patients because they seem to be a bit different, and actually they are. In terms of gender differences, this predominance of female patients in Paragangliomas and Pheochromocytomas is lost when it comes to Fontan patients. It is more frequent in male. And also, when compared to other sympathetic paragangliomas, Fontan patients develop these tumors at a younger age. Therefore, with a lower or shorter time with cyanosis, and with a higher levels of oxygen saturation at the time of diagnosis. However, if we compare these Fontan patients that develop paragangliomas with our Fontan patients that do not develop or have been not diagnosed with paragangliomas, we can see here that their hematocrit and their oxygen saturation, their hematocrit is higher and their oxygen saturation is lower than the rest. So this intermittent cyanosis that we were talking about, these veno-veno collaterals that may be more pronounced, maybe more evident on exercise, might be the reason for that. And when we come to the genetic analysis of this, what we can see is that compared to the general population with PPGL and non-congenital heart disease, in which mutation in IPAS1 is a very rare mutation, is something exceptional. In patients with cyanotic congenital heart disease, we have this mutation in 70% of the patients. But if we look more in detail, you can see here that none of the patients with a parasympathetic paraganglioma, which is a carotid body tumor, none of them had mutation in IPAS1, but nearly 90% of patients with parasympathetic paragangliomas had a mutation in IPAS1. And this is a gain of function mutation. Again, all the mutations were found in this degradation domain, leading to an increase in the activity of HIF2 alpha. So it's again a gain of function mutation. Even in some patients, there's a patient that had several tumors, and he had 5 different mutations in IPAS1, but all in the same domain. So it seems that this cyanotic environment, this low oxygen environment, is a trigger for these cells to mutate and to enhance the activity of HIF2 alpha. And what are the future directions here? I think that, yeah, there are a lot of question marks here, but they are all very interesting question marks, because it is a very, very intriguing and very exciting field of research. First of all, I would like to claim your attention to this paper. This is also a very old patient from Peru, again. In this paper, the authors compared the carotid body size and weight from people dying at the sea level and at high altitude. So they were accidental deaths. They were not deaths from cardiovascular reasons or whatever. So and they were all Peruvians born and living at the sea level, and Peruvians born and living at more than 14 feet above sea level. So what the authors found was that people living at sea level had more or less the same size of the carotid body during their life. And this, whereas people living at high altitude had higher or larger carotid body size in all ages compared to other to their peers here. And this increase was this size was increasing over time. So I told you before that there has been described that an increased prevalence of chemodectomas in that population, and maybe it's not that easy to separate what can be considered an adaptative hyperplasia, which is this, we can consider that an adaptive hyperplasia, to a hyperplasia that has been too much, and then we can consider that a tumor. It's difficult to say that, but maybe we can consider that in these people, in people living at high altitude, this carotid body is developing an adaptive hyperplasia. So the first thing that we have to think about right now is, do we really have to resect the carotid body tumors in our patients with cyanotic congenital heart disease? Is this an adaptive mechanism? And then are we doing any good to them doing that? If this is a risky operation, and if it's an adaptive mechanism, maybe we are doing harm instead of doing good for this, doing that. So should we just do a watchful waiting strategy? And if there is any compromise of the neighboring structures, then we can do something. But if not, just leave it alone. That's one thing. And the other intriguing thing is the Fontan patients. Why these patients are developing these tumors at an earlier age, predominantly men, when the rest of tumors are more frequent in women. That's something to be established, to be studied, because maybe the peculiar circulation of Fontan circulation with chronic low cardiac output, increased systemic venous pressure may enhance this tissue hypoxia, and then that may trigger a more pronounced response, or an earlier response in terms of developing tumors. Or maybe this intermittent cyanosis, being cyanotic, then non-cyanotic, and then a relapsing cyanosis, maybe this is a more profound or more intense trigger for developing these tumors. And actually, it has been seen that intermittent cyanosis triggers or has different mechanisms to adapt than the chronic hypoxia. So maybe our Fontan patients are a model of intermittent cyanosis for the development of this type of tumors. And with that, I think I come to my conclusion, or to my concluding messages. I think that it's clear that patients with congenital heart disease and chronic cyanosis are at risk of developing this type of tumors. Carotid body tumors are non-secreting tumors. They are usually asymptomatic. They are usually incidental findings, and they are more expected in older, non-repaired patients, and predominantly female. Should we consider that an adaptive hyperplasia or not? That's a question. Should we, in that case, should we leave them alone and don't operate on those patients? And on the other hand, Fontan patients with this amazing circulation but so fragile are more prone to sympathetic secreting tumors, and are developing at a younger age, and predominantly in male, which is something very different from the rest of PPGLs. And finally, the role of this EPAS1 gene somatic mutation in patients with sympathetic PPGLs deserves further study, because it's a very intriguing finding. And this is my last slide. This is the Vall PPGL CCTH working group. So here you can see Rodrigo Toledo. He's the leader of this whole consortium, together with Carlota Regnilla from the Vall Institute of Oncology. Ana Casteras, she's the endocrinologist, and Berta Miranda, she's one of the cardiologists at the CCHD unit. I want to thank them all for their enthusiasm, for their support, and their help in preparing this presentation, and for the work that we have been doing and we are going to do. And I think that's all from me. Thank you very much for your attention.
Thank you, Laura, for a fantastic, amazing talk, and eye-opening of a new topic that we have to take care of in this complex population. So Candice says in the chat that amazing talk, Laura, so I congratulate you for the talk. Dr. Thon has a question in the chat. So just for everyone, just remind you that if you want to ask any questions, either type it on the chat or unmute your microphone and ask directly the question. So Dr. Thon says in the chat that fantastic talk, Laura, thank you. Should we be screening Fontan patients with arrhythmia for PPGL?
I think that we should have a very low threshold for screening these patients. It's so easy to do. It's just the analysis of metanephrines in urine, also in blood, but either in blood or in urine, it depends on the center. It's very easy to do, and I think that any weird symptom or not weird, arrhythmias are maybe one of the symptoms or the presentation of this type of tumor. So I would do for sure this in infantile patients, but also in other type of symptoms that are weird or that could make you think about releasing catecholamines. I think that's for sure what I would do, what I'm doing.
So I have while people think about another questions, I have a question. I found very interesting the concept of having a adapted mechanism of a hyperplasia of the carotid body in this patient. So have you looked at the size of the carotid body in your population and compare between those with tumors and not tumors to see whether that hyperplasia mechanism is there? Seems that in the paper that you show with Happitude is very, very nicely shown, but have you looked at that in your population?
We are doing that right now. So we are doing this study right now. That's Berta Miranda is doing this at this moment, but we don't have the results at this moment. So maybe I hope in a few months I can answer that. Sorry, that comes from the idea of the Peruvian study, looking at the size of the carotid body in people living at high altitude, makes you think that in our patients that should be more or less the same.
Mm-hmm. No, yes, that's why I asked the question, because it seems to be a very interesting finding if we demonstrate that. So, Wim?
However,
Laura, no.
Yeah. However, I think that although it seems like hypoxia equal pheochromocytoma and paraganglioma, carotid tumor, and that stuff. There's something with the cyanotic congenital heart disease that is different from high altitude, because if you look at in the literature, you will not find an increased risk of pheochromocytoma and sympathetic paraganglioma in people living in high altitude in Los Andes. So there's something here that makes a difference in patients with cyanotic congenital heart disease.
Erwin?
Thank you very much, Laura, for this fantastic talk, and you're opened or pushed up a new door of problems in patients with congenital heart disease. And I told it before, Laura and I have something in common in our life. Laura and I started on the same day in Toronto on February the 1st, 2006. She started as a fellow and I started as a staff physician. Okay.
Yes.
Yes. So actually, it's very difficult to diagnose these tumors, even in non-congenital heart disease patients, because the symptoms are usually non-specific, very atypical. Nobody thinks about this diagnosis, and there's a big deal or large delay in diagnosis these tumors, even in non-congenital heart disease patients. I remember of 2 patients here in Toronto who had this type of tumors. Both of them underwent surgery. And in retrospect, I also remember one in Zurich. When I was in Zurich, I had a patient with an Eisenmenger VSD, and she always had atypical symptoms, some sweating and an atypical tachycardia. Nothing could be diagnosed. And we all think that this has something to do with her cyanotic congenital heart defect, maybe some hypoventilation. She gets tachycardic at night, sleep apnea. And then finally, then Matthias Krutmann, a few years later, he presented all the time the symptoms they found out that that's a Pheochromocytoma, that's what she had then actually, which we missed a few years ago. We didn't even think about this. And I think in all these patients with Fontan patients or cyanotic patients, they have sometimes very atypical symptoms, and we always attribute these symptoms to their underlying congenital heart defects. But there is a red flag. Some of these patients may have such a tumor, and then we should arrange appropriate imaging.
Mm-hmm. Yeah, I completely agree. I think, as I said, the screening doesn't require advanced imaging. The screening, you have to confirm that with advanced imaging and also with other type of things. But the screening is quite simple, and I think that we should all have a very low threshold for doing that screening in our cyanotic patients, and mostly in as Rafa said or somebody else. I'm sorry, I don't remember. In Fontan patients, because those patients have such a fragile equilibrium that can be disbalanced with such a catecholamine secreting tumor. So to me, the whole idea here is that we should screen more and more our patients to look for that. And my residents and my colleagues always laugh at me because I am very obsessed with that. And I'm screening all my patients that I have the least suspicion. To date, I have not discovered any new one, but anyway, I think that that should be done.
I think it should not be routinely screened.
No.
But there need to be some symptoms or atypical symptoms.
Yeah.
Which you cannot explain. You have to think of these tumors, because we also need to be cost effective. Coming out to what I said last week, the Swiss are born as accountants, because you always need to think what do I get, what they pay for. This is very important.
Yeah, sure.
This is Candice. I just wanted to say one thing.
Meaning if there are atypical symptoms which you cannot explain.
Candice?
Well, I was just going to say, sometimes one of our patients, it was picked up when we were scanning the liver in a Fontan liver. So I'm just saying, if we can do the metanephrin screen, but sometimes it might be picked up on abdo imaging we do for other reasons.
So I mean, in my experience, I diagnosed 2 of these patients in 3 in my life. 2, one is a Menger, one cyanotic with pulmonary atresia when I was in London, and here in Toronto I have a Fontan with 3 Paragangliomas resected and relapsed. So and now actually has one of the ones he has is very in a location that is very, very high risk surgery. So, but I agree. If you don't think about it, you don't get it. Probably if you have come across one in your life, then gets in your brain, and then your threshold become much lower to ask for metanephrines.
Yeah.
And I agree that it's something that we need to look for with minimal symptoms, but you need to think about it. That's, I think, one of the problems of not diagnosing them. People do not think about it, and therefore takes ages to get diagnosed. I have 2 more questions in the chat. So one is, if you happen to screen for paraganglionic tumors in patients with cyanotic congenital heart disease, what do you think is the percentage of prevalence that we can find? So if you just screen regularly without symptoms, and that's a $1 million question, I think. Yeah,
I think that's actually the $1 million question. If we, I mean, the numbers that comes from Madrid, from the people from La Paz, the prevalence is around 3 to 4% of people with ongoing cyanosis, which I think that they didn't include the Fontan patients, or they include Fontan patients with cyanosis at the moment, if I'm not wrong. Anyway, I think that the numbers will go, probably that will be the range. And it always depends on which patients you include in these numbers, in these estimates. But probably it's that. But I'm sure that we need robust studies to ascertain that. It's only
it's another complex question here in the same line. So if we move to the Fontan patients, those that do not have this desaturation, at least objective desaturation, because one of the in the Fontans is you might not have a saturation or rest, but you might exercise and you get saturation. But those with no fenestration, no desaturation, are these patients at risk of developing tumors? That's the $1 million. I have to say, to comment on that question, I can say my patient here with Fontan has 98% saturation. And no desaturation.
No desaturation of the exercise. I think that that's something that we are missing for sure. There are many things that we are missing here. That's only the first step of knowing what's happening here. I think that there are a lot of things that we don't know, and this relationship between between cyanotic congenital heart disease, not people that are still cyanotic, but cyanotic congenital heart disease and the development of this kind of tumors is, I think it's goes beyond HIV probably. So I don't know. There are also patients that have been had a complete repair and they have a cyanotic background and they also develop this kind of tumors. Probably the incidence of the in this type of patients is lower, but I think that this idea of the intermittent cyanosis in the Fontan patients that have a relapse on the hypoxia, I think that's something to look into. But yeah.
So Dr. Bravo from UCLA says that she agreed with Dr. Silverside during the abdominal MRI. You can discover these adrenal masses, and they had, I guess you mean in UCLA, so they had a Fontan patient that went from non-secreting to secreting paraganglioma and ended up in cardiogenic shock and requiring ECMO.
Wow, that's wow. I didn't catch the Candice comment. I think that
Candice said that sometimes you pick them up on the abdominal ultrasound or when you do abdominal MRI to look at the liver. Of course, you just look at the abdomen, just pick a mass.
And actually, in that paper from the Korean colleagues, they found, I think it was a couple or three Fontan patients that had at the same time, but not at the same time, that were first diagnosed with hepatocarcinoma and a few months later with pheochromocytoma or paraganglioma. So maybe the link, the tumorigenic environment or trigger is something that not only affects this type of cells, but also the hepatic cells.
Mm-hmm. There's another question here, from Dr. Naumann, thanking you for the excellent talk. Regarding the screening, what is your strategy with the screening regarding imaging and blood markers like catecholamines? So how do you screen these patients to make this cost effective? So do you imaging all of them or just do the catecholamines? And if they are negative, because of course if the catecholamines are negative, you're not going to diagnose a paraganglioma, but or a non-secreting tumor. So what is your strategy?
My strategy is, as I said, I have a low threshold for ordering catecholamine study. We are doing urine analysis right now, but as I say, it depends on the center, and it's very easy to do. It's something the patient only has to be on a 5 days diet, which doesn't have to be that strict. I mean, they only have to be of paracetamol and of caffeine and only a few things more. That's it. And they do this 24-hour urine collection, and that's very simple to do. And I think it's not that costly, so not that expensive. So I think that might be a good strategy. Then if it comes positive, if the tumor is secreting, then you have to look more in detail on that. But if it's negative, if it's a carotid tumor paraganglioma, or if it's a parasympathetic paraganglioma that is causing no harm in terms of no bothering the surrounding structures, then leave it alone. I think that's not, the whole thing with the carotid body, I think that deserves more attention from us, because I think that's not that clear that we should remove those tumors. I'm not stating that we have to leave them alone, but
No,
we,
no, I agree.
we should think. Yeah.
I don't think we know the answer, and that is why we have to do more research on the topic. So I think it's 9 o'clock, and before finishing, I want just to remind a comment that Dr. Toledo, who is the leading author of this project, wrote in the chat that if you have any congenital heart disease patient with a paraganglioma operated and want to collaborate in the genetic study they are running, he left just his email there or contact Laura just to join the study.
Yeah, sure.
On that note, Laura, if you want to say anything?
Yes, I just want to invite anyone that has interest in that or wants to share this consortium to just be part of it, because it's open to everyone.
On that note, so I thank you again, Laura, for the excellent talk and to remind us about such an important topic, and to all of you that have joined us today. So thank you for joining, and we'll see you back here in a couple of weeks. So good morning, good afternoon, or good evening, wherever you are in the world. Bye-bye. Thank you.
Thank you. Thank you
Bye,
very much.
Laura. Thanks for the great talk.
Hi, Candice. Good to see you.
Nice to see you. Yeah.
Bye-bye.
It's not too different here than when you left. But anyway,
Yeah.
hopefully I see you when I come to ESC in Barcelona.
Oh, yeah, for sure.
Yeah,
we have to meet.
Yeah, it would be nice to catch up with you. But
Yeah,
anyways,
sure.
okay. Thanks so much for doing the talk. It was awesome.
Thank you.
Okay.
Thank you very much.
Bye.
Bye, David.
Bye, Laura. See you.
Bye.
Bye.